short answer questions as well as a few MCQs. This is a part of our 90-day university pre-final mastery program in which we are going to rapidly revise all the important questions, volatile facts, and high-yield topics. So we are going to discuss a long essay question, a few short essay questions, and also a few MCQs in this session. So we have in Auricle recorded classes, live classes. We have practical sessions, exam modules, and also hard copy books. Recorded classes are very important for flexible learning and also conveniently revise all the exam topics in one go. Live classes, we cover in-depth and all past 10 years papers, previously asked questions, as well as there is an interactive learning based on MCQs, Viva Voice, etc. There is an express exam module in which you can quickly revise all the previously asked questions in just 20 hours. And in this, we will also be telling you how to write, present, and answer to get maximum marks out of it. There is a one-to-one doubt clearing session. There are hard copy note sets and question banks are also available with 3 levels of expertise, which can be used for NEET PG, Proff exams as well as FMGE exams. There are practical sessions also. These are the subscription plans which you can see in the website. So today's first long essay question is a case-based question. So we can see here that this is a 45-year-old male who is presenting with severe chest pain and sweating. Okay, there are very good clues which are given here. Right, severe chest pain is there and sweating. Okay, on admission, there's an ECG finding also which is given for you, which is ST segment elevation with T wave inversion. So all the history which is given here is extremely classic. So you have severe chest pain. Usually you can be given a history which is radiating to the arm. Okay, that is another classic history which can be given for you, radiating to the arm. Usually the right arm can be given to you. Okay, right or even left arm can be given. So you will have sweating. Okay, severe chest pain and sweating. And another classic history here is going to be your ST segment elevation. So ST segment elevation in the ECG is very classic. Whenever you find ST segment elevation, always think of myocardial infarction. Okay, very rarely it will be something else when you're given ST segment elevation and T wave inversion. So this is a classic case and classic history of myocardial infarction. So probable diagnosis is acute myocardial infarction. Okay, so what are the clinical indicators? So whenever you present it, you have to write what are the indications that led you to the diagnosis. So you got severe chest pain, you also got sweating. Okay, sweating, palpitations are very common symptoms which can be associated with myocardial infarction. And also I said pain radiating to the arm. So ECG changes, ST segment elevation and T wave inversion point towards the diagnosis of myocardial infarction. So the laboratory diagnosis. Okay, this was a sub question which was asked for you. So what is the laboratory diagnosis? First of all, most important laboratory diagnosis are cardiac biomarkers. Cardiac biomarkers are used for the diagnosis of myocardial infarction. So usually a single marker can be done or multiple markers in combination can also be done for diagnosis. Okay. Serial measurements are usually done to confirm the track and progression to see if the myocardial infarction is subsiding or is there any reinfarction. So this is how the graph looks like. This is 0 hours of onset of myocardial infarction. And you're going to have a spike in myoglobin. Okay, myoglobin, always remember, is the first marker which is elevated during a myocardial infarction. But the catch here is myoglobin is a very non-specific marker. Okay, myoglobin is a very non-specific marker. Why is it non-specific? Because myoglobin can not only be present in the cardiac muscle, but the name itself says myoglobin. So it can also be present in the skeletal muscle. Okay, so any skeletal muscle injury can actually result in increased myoglobin. So this is a very non-specific marker and it is not at all specific for the cardiac tissues. but it can be useful since this is the first marker which is elevated during a myocardial infarction. And the second marker which comes in after myoglobin is the CK. CK is creatinine kinase. Okay, we know that there are three types of CK. We have CKMB, we have CKMM, and we have CKBB. Okay, so we have a few markers associated with CK, but CKMB is the one which is actually specific for the cardiac muscle. Okay, the rest are seen in other tissues, and CKMB is the one which is specific for the cardiac muscle, and this is the second marker which is elevated after myoglobin. But as we know, CK is also not very specific to the cardiac tissue since it can be confused with CK from the skeletal muscle as well. And then we have another marker, the troponins. We have troponin I and troponin T. Okay, so these are troponin I and T. Remember, troponin I and T are the markers which come in, and then they are going to actually stay for a very long time, till 140 days, till more than 80 days. You can see it in the serum. So troponin I is a very specific marker for myocardial infarction. And then we have LDH. If somebody asks you which marker stays in the serum for the longest period, then that is LDH. But is LDH specific? No, LDH is very non-specific. Why? Because LDH can be seen in various tissues. Even in the red blood cells, you can see LDH. So there are many types of LDH which can be seen in various tissues. It's not at all specific for the cardiac tissue. But still, LDH is a marker which stays in the serum for very long time after a myocardial infarction. So in that way, LDH can be useful. So why do you need to do serial measurements of these markers? Because see, you can see here that the markers are going up and they are actually coming down after a point. So for example, if after 40 hours, the markers again go up, what does it indicate? It indicates a reinfarction or a remyocardial infarction. There's a second infarction. That is why it is important to serially monitor these markers. Okay, so remember myoglobin, first marker, CKMB, specific for the cardiac tissue. Troponin I is the most specific marker for the cardiac tissue and myocardial infarction. LDH is the longest marker which is identified in the serum after a myocardial infarction. Okay, so these are for laboratory diagnosis of myocardial infarction. Now we're going to discuss a few gross as well as microscopic changes which we can see after infarction. Okay, gross and microscopic changes. Remember, we know irreversible and irreversible injury from a general path, right? So reversible injury, you can reverse a myocardial infarction to a normal state. If you reperfuse the heart, for example, there is an infarction here, okay, and within 30 minutes, if you're able to remove the clot and able to reperfuse the heart, then the myocardium will return to normal. Otherwise, it will go into irreversible injury. So that is the basic. So 30 minutes is the window time where you can actually reperfuse the heart and bring it to a normal or a normal state of function. If 30 minutes has crossed, then it's going to be irreversible injury. As the name says, irreversible, so it's not going to be reversible. But still we do try to reperfuse the heart after 30 minutes also. Okay, so in that case, you will have something called as reperfusion injury, which we will be discussing in further sessions. So irreversible injury will occur. So what are the changes which will occur in 30 minutes to 4 hours? In 30 minutes to 4 hours, usually there are no gross features which you can see grossly. So it's very early, so you won't see any gross feature. Only the first light microscopic feature is going to occur in 30 minutes to 4 hours. What is it? It is waviness of fibers. You can see here, this is the waviness of fibers. You can see how wavy these myocardial fibers are. Okay, usually a normal heart is something like this, spindly in appearance. It's not very wavy. So you can see this waviness of fibers. First gross change is going to occur in 4 to 12 hours. Before that, no gross change. Only 4 to 12 hours, you will have the first gross change, which is occasional dark mottling. Why does it occur? Because of coagulative necrosis. Microscopically, you're going to see coagulative necrosis. From our general pathology, you can remember that coagulative necrosis usually occurs in solid organs, like the heart. 12 to 24 hours, again, you're going to have dark mottling, which is increasing, and then ongoing coagulative necrosis. 1 to 3 days, you're going to have early 24 hours, and 1 to 3 days, you will have neutrophilic infiltrate. Okay, neutrophilic infiltrate, because we know that inflammatory cells of the acute inflammation is neutrophils. So first you will have neutrophils. After that you will have macrophages. So chronic inflammatory cells are macrophages, right? So after that, dark mottling is going to reduce and yellow tan is going to be there. So that is, yellow tan is the late change and dark mottling is the early change. And after 10 days, you're going to have phagocytosis, because we know we have lots of macrophages. So they're going to phagocytose, produce granulation tissue. And then finally, we're going to have a white scar formation after 8 weeks because of increased collagen deposition. More than 2 months, what we're going to see is complete scarring with dense collagenous scar formation. So these are the gross features. You can see this is what is dark mottling. Okay, this here is the dark mottling. This is dark and dark mottling, and this is the later stage. You can see this is where this is a yellow. This is the yellow tan over here, and you can see around this yellow tan, you can see a reddish appearance. Around this yellow tan, you can see this red colored. This is the hyperemic border with central yellow tan softening. Okay, when does this occur? When does this yellow tan and this hyperemic border occur? It occurs around 3 to 7 days. Okay, and after that, when it becomes a white scar, it is 2 to 8 weeks, and then complete scarring occurs more than 2 months. Okay, this is a very tedious table and very tedious to remember, but very simply remember 0 to half hour, no changes. After that, irreversible injury. Irreversible injury, 4 hours, no changes. Okay, light microscopy, first change is waviness, and then early coagulative necrosis, and then neutrophils, and then macrophages, and then scar formation. Okay, so that is a simple way to remember. Now we are going to discuss a few short answer questions. This one is atrial septal defect. What is atrial septal defect? As the name says, we know we have in the heart, we know a right atrium, left atrium, right ventricle, and the left ventricle. Okay, and now we in between these atrium, we have a atrioventricular septum. We have a atrioventricular septum here. Okay, which separates the ventricle. Which separates. So between the right ventricle and between the right atrium and left atrium, we have an atrial septum. So this is the atrial septum. And then between the right ventricle and left ventricle, we have a ventricular septum. So when there is a defect, here, usually there is no septum which is present normally. Okay, there should be no communication. Then there will be a septum in the embryonal stage, but it will close due to excess pressure in the left atrium after birth. But when this continues to persist, it is known as an atrial septal defect. Okay, this septum continues to persist and it is known as an atrial septal defect. Okay, so that is an atrial septal defect, and it is an abnormal opening in the atrial septum allowing left to right shunting. So what will happen in atrial septal defects? You will have left to right shunting. Always remember, whenever you have a shunt, you will have a shunt from the high pressure area to the low pressure area. As we know, right is venous supply, okay, and left is arterial. We know from the left ventricle we're having aorta, and the right ventricle we're having the pulmonary trunk. So this is the aorta, and we know always arterial pressure is higher than the venous pressure. So always blood will flow from the left to right whenever there is a shunt from the left to right. So left to right shunting happens because there is a pressure here. Similarly, even in the VSD, which is ventricular septal defect, you will have a left to right shunting. Okay, So what happens? Oxygen, we know left side has the oxygenated blood. So oxygenated blood flows from the left atrium to the right atrium. What will happen because of this? Because oxygenated blood flows from the left atrium to right atrium, the pulmonary pressure is going to go high, right? The pressure in the right side is going to go high. We know pulmonary trunk is going from the right ventricle. So pulmonary blood flow is going to go high. What will happen if pulmonary blood flow will be high? It will cause pulmonary hypertension, and because of backflow, you're going to have heart failure. And another unique complication which you can have is a paradoxical embolism. This usually happens in the older patient. What is a paradoxical embolism? We know what is an embolism. Embolism is nothing but a thrombus which has separated and formed a small part of a thrombus is the embolism. So that usually emboli are formed in the veins. Okay, remember the deep vein thrombus, DVT, right? The deep vein thrombus. So from the deep vein thrombus, a small emboli comes into the circulation. What will happen? Because this is a deep vein thrombus, this will go into the right side of the heart. Okay, this will go into the right side of the heart. And usually what this will cause? This will cause a pulmonary embolism. Correct, because this will go to the right ventricle and go to the pulmonary trunk and cause a pulmonary embolism. But in this case, since there is a septal defect here, it can go to the left atrium and can through the aorta, it can go to the cerebral arteries and cause a stroke also. So that is what is known as a paradoxical emboli. Okay, so that is a unique complication which can happen along with the atrial septal defect. Okay, so I'm going to just review a few of the congenital heart diseases, which are cyanotic and acyanotic. Okay, a simple concept which you can remember is always the left to right shunts are going to be acyanotic. Okay, whenever the shunt is going to be left to right, it is acyanotic. Why? Because left side harbors the oxygenated blood. So oxygenated blood is going to the right side. So oxygenated blood is going to be supplied to the body anyways. Okay, so in that case, oxygenated blood is mixing with the deoxygenated blood, so there won't be much of oxygen deficit. So that is why this is an acyanotic disease. All the left to right shunts, but right to left shunts are always going to be cyanotic. Okay, because there is no mixing of deoxygenated blood in case of right to left shunts. So that is an example. So what are the diseases which can cause left to right shunt? We know a few diseases. ASD, we know. Atrial septal disease, ventricular septal defect, we know. And we also have to remember a patent ductus arteriosus, which can cause left to right shunt. Okay, right to left shunt, we have to remember tetralogy of Fallot. Okay, we will be discussing it because it's also a short answer question. Tricuspid atresia. Okay, tricuspid valve is something which is present in between the right atrium and the right ventricle. Okay, when there is no tricuspid atresia, there is going to be a right atrial hypertrophy. So that will cause a that is a cyanotic disease here. So we also have a few diseases like TGA, which is transposition of great arteries, and truncus arteriosus. So these are all right to left shunts, which are cyanotic diseases. Okay. So we're going to now discuss tetralogy of Fallot, which is a very important question. You have to remember tetralogy of Fallot. It will be tested many times. So tetralogy, as the name says, you are going to have four components in tetralogy of Fallot. So what are the four components you can see here? First one is pulmonary stenosis. Okay. First one is pulmonary stenosis. Pulmonary stenosis is nothing but left ventricle, you have the pulmonary trunk and you have the pulmonary wall over here. So there is stenosis of the pulmonary wall. So imagine when there is a stenosis of the pulmonary wall, blood from the right ventricle is not going to go properly. Okay, remember just in this order. So remember, if there is pulmonary stenosis, what will happen? Right ventricle is going to harbor more and more blood and it is going to increase in size. So pulmonary stenosis, right ventricular hypertrophy. Okay, and then what you have, the third one is overriding of aorta. Okay, overriding of aorta. Aorta is from the left ventricle. And then you have ventricular septal defect. Okay, two in the pulmonary and left ventricle, aorta and ventricular septal defect over here. So these are the four things which you have to remember in tetralogy of Fallot. Okay, we know that this is a cyanotic heart disease. So you will have cyanosis as a complication. Okay, and then you are going to have death spells. The child will have death spells, and when the child squats, the pressure will get relieved, and cyanosis can be relieved for a very momentarily period of time. And then you have heart failure, and then there is a risk of endocarditis also. So you're going to have these four symptoms. In radiology, there is a very important finding which you will see in tetralogy of Fallot, that is boot-shaped heart. Because of enlargement of right ventricle, will have what is known as boot-shaped heart in radiology, in tetralogy of Fallot. So this is tetralogy of Fallot which you have to remember. The next one which we have to discuss is myocardial infarction pathogenesis assessment. So what is the pathogenesis of myocardial infarction? We know myocardial infarction is nothing but if the blood supply to the end organ is, blood supply to the heart in this case is reduced, then you are going to have infarction, right? So what is the cause of infarction? We know that if there is an atherosclerotic plaque which is blocking the artery, which is impairing the blood supply to the heart, then this will result in myocardial infarction. Okay, or if there is a thrombus formation in the coronary artery, it can also result in myocardial infarction. So atherosclerotic plaque, the most common and most important reason which you have to remember in the pathogenesis, and then thrombus formation can result in myocardial infarction. So we know what are the gross and microscopic changes. We just discussed them. So we know first gross changes, the dark mottling, and then we know coagulative necrosis is going to occur, and then neutrophilic infiltration is going to come, macrophages, phagocytosis, and then fibrosis over time. So this we just discussed, this we know. And what is the laboratory diagnosis? This also we have discussed. So what is the first enzyme which is going to get high? We know it is myoglobin, right? Okay, then we have CKMB, and then we have LDH, which is the long-lasting one, and then troponins which are specific, and in troponin I is the most specific. So what are the complications? We're going to discuss complications in detail now. Complications can be split into early complications and late complications in myocardial infarction. So most early complication is ventricular arrhythmias. Ventricular arrhythmias are the most early complication. It can occur within less than 4 hours also. Okay, there can be tachyarrhythmias and bradyarrhythmias. Tachyarrhythmias are nothing but fast rhythm. Tachy is that we know tachycardia, right? Tachycardia and bradycardia. So similarly, there are tachyarrhythmias and bradyarrhythmias. Bradyarrhythmias can result in heart block. Okay, so these two are early complications. And then cardiogenic shock is also an important complication. What can happen is this thrombus which has formed, it can actually form an emboli, and it can go ahead and cause infarct some cerebral vessels, go into the internal carotid artery and cause stroke also. Okay, so after 3 days, ischemic complications can happen. Okay, rupture. Okay, remember after 3 days, you will have all kinds of rupture. Okay, before 3 days, you will have heart blocks, you will have arrhythmias, you will have stroke. After 3 days, you will have all kinds of rupture. Papillary muscle rupture. Papillary muscle is the muscle which is present between the left atrium and the left ventricle. Okay, So the mitral valve and has papillary muscle. So this can result in papillary muscle rupture because of ischemia to the wall. The wall doesn't get enough blood supply and can result in rupture. Then you can have ventricular septal rupture. Okay, ventricular septal rupture. Ventricular septal rupture, we know ventricular septum is between the right ventricle and the left ventricle. So septal rupture can. Left ventricular free wall rupture is mortality is very high because if the left ventricular wall gets ruptured, then there's high chances of sudden death because of loss of such significant amount of blood. So we're going to have 50% mortality in this. So remember, more than 3 days, all kinds of rupture will happen. And most important thing which you have to remember is Dressler's syndrome. Dressler's syndrome is post myocardial infarction pericarditis. Okay, pericarditis usually itis you can correlate it with an infection caused by an infection, right? But this is not an infection. This is an autoimmune reaction. Okay, this is an autoimmune reaction which occurs after myocardial infarction resulting in pericarditis. And this is one of the late complications of myocardial infarction, usually occurs more than 2 weeks. Okay, so this is Dressler's syndrome. So these are the complications of myocardial infarction. Okay, so now we are going to discuss another short answer question here. And this short answer question is actually Jones criteria. First of all, you have to know what rheumatic fever is. Okay, rheumatic fever is a disease which is caused by beta hemolytic streptococcus. It is a disease caused by beta hemolytic streptococcus. So what happens? We know streptococcus is an microbe which causes URTI, upper respiratory tract infection, pharyngitis, and all these things. So after URTI, certain individuals develop a cardiac condition or a carditis, which is known as rheumatic fever. Okay, so what is the criteria to diagnose this? So that is why we use Jones criteria to diagnose this condition. So what are the criteria? There are two types of criteria. We have major criteria and we have minor criteria. What are the major criteria? Carditis, as I said, definitely carditis has to be there as a major criteria. Along with it, you are going to have migratory polyarthritis. Okay, there is a migratory polyarthritis. What is migratory polyarthritis? One day you are going to have the joint pain will change its site. Okay, today I am going to have joint pain in my knee joint, and then the next day it will be an ankle joint pain. So the joint pain is going to change its site. That is known as a migratory polyarthritis. And then you have Sydenham's chorea. Okay, chorea is difficulty in coordination. So Sydenham's chorea. And then erythema marginatum. And then subcutaneous nodule. So these are the major criteria which you will have. There are some minor criteria also: fever, arthralgia, elevated acute phase reactance. So these are very non-specific and hence they are put under the minor criteria. So diagnosis is presence of two major criteria or one minor criteria or two minor criteria with evidence of preceding streptococcal infection. If there is a preceding streptococcal infection documented, then two minor criteria is sufficient. Okay, so I'll just tell you a mnemonic to remember this. Okay, instead of O, I'm going to write it like a heart. Okay, J is joint pain. Joint pain is for migratory polyarthritis. Okay, and then this is for carditis. N is for nodules, subcutaneous nodules. Okay, E is for erythema marginatum. Okay, S is for Sydenham's chorea. Okay, so this is just an easy way to remember Jones criteria. Okay, so next is Liebman-Sack endocarditis. What is Liebman-Sachs endocarditis? First of all, what is endocarditis? As the name says, it's very specific, very easy, right? Endocarditis, inflammation of the endocardium. So definition, it is a form of non-bacterial thrombotic endocarditis. Okay, for endocarditis is usually caused by infection. So then it is called as an infectious endocarditis. But this one is a non-bacterial endocarditis, thrombotic endocarditis, because it has thrombus formation associated with it. So associated with systemic lupus erythematosus. So you can remember LSE, right? Liebman-Sachs endocarditis. So LSE is associated with SLE. What are the features? You will have small sterile vegetations on both sides of the valve. This is very important. This is very characteristic of Liebman-Sachs endocarditis, both sides of the valve. Okay, this is only one endocarditis which is associated with vegetations on the both sides of the valve. Also remember, vegetations are sterile. There are no bacteria which is formed, because this is not associated with bacteria, and this is a sterile form of endocarditis associated with SLE. So most commonly affects the mitral valve and the aortic valves. Okay, what is the pathology? SLE we know is an autoimmune disease caused by immune complex deposition. So that is the pathology here, immune complex deposition and fibrinoid necrosis. Okay, so this is it. Now these are a few vegetations which you have to remember. Okay, so first you see the vegetation over here. This is along the line of closure. You can see how neatly these vegetations are arranged. These are small in size and completely along the line of closure. If you see these kind of vegetations, these are associated with rheumatic heart disease or rheumatic fever. Okay, rheumatic heart disease is what you will see. These small vegetations which are arranged along the lines of closure. Okay, other vegetations, these vegetations which actually destroy the valve, as you can see here, these vegetations are destroying the valve, these are infiltrating the valve, these are not along the lines of closure. Valve destruction is there. So these vegetations can actually have bacteria in them, and these are associated with infectious endocarditis. Okay, these are not along the line of closure, they are valve destroying vegetations. You can see another type of vegetations here, again along the lines of closure. These are also along the lines of closure, but these are slightly bigger in size. Okay, these are slightly bigger in size, and you can see not very much destroying. So these are associated with non-bacterial thrombotic endocarditis. What are non-bacterial thrombotic endocarditis? What are the causes? Non-bacterial thrombotic endocarditis can be caused by an underlying malignancy. Okay, underlying malignancy. That can be an underlying malignancy like a carcinoma of stomach, carcinoma of pancreas, or any underlying malignancy can result in a thrombosis and result in these kind of non-bacterial thrombotic endocarditis. And these are going to be sterile as well. Okay, because these are non-bacterial. This one is what is Liebman-Sachs endocarditis. You can see this is the only endocarditis which has on both sides of the valve. So this is Liebman-Sachs endocarditis, which is associated with SLE, and the vegetation can be seen in both sides of the valve. Okay, so these are the types of vegetations which you have to remember. And then now we are going to discuss cardiomyopathy. What is cardiomyopathy? Again, as the definition reads, it is a disease of heart muscle, function of the muscle. Okay, it's cardiomyopathy. Something is wrong with the cardiac muscle. There are three types of cardiomyopathy. There are more other types also, but these three types which you have to definitely remember is the dilated cardiomyopathy, hypertrophic cardiomyopathy, and the restrictive cardiomyopathy. Now, what happens in these conditions? Okay, you have dilated cardiomyopathy. What will happen? The ventricle is going to be dilated. Okay, because of either it can be because of systemic genetic causes, or it can be because of environmental causes. So the ventricle is becoming dilated and it is not able to pump blood. So it is going to accumulate all the blood and get more and more dilated and lose its function. So Which kind of dysfunction is this? It is systolic dysfunction, because it is not, the heart is not able to enter into systole because of extreme dilatation of ventricle. Now, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is because of diastolic dysfunction. Okay, restrictive cardiomyopathy is also due to diastolic dysfunction, because something is restricting the heart from dilating. Okay, systole is normal, heart is able to contract properly, but because of some deposition, okay, because of fibrosis or because of deposition of any material from the outside like amyloid, the heart is not able to dilate. So there is restriction in dilation. So this is a diastolic dysfunction. Diastolic dysfunction in both hypertrophic and restrictive cardiomyopathy. Okay, so restrictive cardiomyopathy, diastolic, usually right-sided. Okay, this is systolic dysfunction. Hypertrophic is also diastolic dysfunction. The age is very important in these conditions. Usually, hypertrophic cardiomyopathy occurs in a very younger age group. Okay, and the most important history which you will get if you get the case in hypertrophic cardiomyopathy is you will get the history of a 20-year-old or a 20-something athlete. Okay, and this athlete is going to, because of some physical exertion, sudden death. Okay, this is what the history usually you get in a hypertrophic cardiomyopathy, and this is a very classic history of hypertrophic cardiomyopathy. What are the pathological features which you will see? It is asymmetric septal hypertrophy. In hypertrophic cardiomyopathy, you're going to see here the septal hypertrophy. Septum is extremely hypertrophic and asymmetric. Okay, myocyte disarray and also outflow obstruction. So what are the genes involved? Because this occurs in a younger age, this is definitely associated with genetics. So what are the genes involved? You're going to see defect in myosin heavy chain. You're going to see defect in myosin heavy chain proteins. Okay, so this is the defect. Occasionally athletic induced, athlete's heart. Okay, so if you get the 20-year-old athlete with sudden death with some exertion, physical exertion, then always think of hypertrophic cardiomyopathy. And what are the pathologic features? Asymmetric septal hypertrophy you can see, as you can see here. Okay, and then you can see myocyte disarray, outflow obstruction also. And then what else can you see in dilated cardiomyopathy? Dilated cardiomyopathy, the most important reason is viral myocarditis. Alcohol is very important. Postpartum and chemotherapy. Drugs can cause dilated cardiomyopathy. So what will you see in dilated cardiomyopathy? Enlarged heart. As we know, the ventricle is going to be enlarged. So thin walled ventricles and biventricular dilatation. Both the right and left ventricle can be dilated. So as we saw hypertrophic myopathy, we had myosin heavy chain. In this, we have to remember a protein which is titin protein, which is associated with familial dilated cardiomyopathy. Titin is associated with familial cardiomyopathy, dilated. Okay. Restrictive, as you know, something is restricting. Stiff myocardium. Why? What could be the reason? You can have sarcoidosis, amyloidosis. Okay. You can have any malignancy, which is the reason. And carcinoid. Carcinoid is usually, carcinoid tumors are associated with fibrosis. So carcinoid and hemochromatosis. These are the common causes of restrictive cardiomyopathy. This is less common. Genetics is very less common. Usually causes are some restriction like fibrosis, sarcoidosis, amyloidosis, any malignancy resulting in fibrosis, carcinoid syndrome, or hemochromatosis. So these are the causes of restrictive cardiomyopathy. Okay. So this is restrictive cardiomyopathy over here. You can see there is lots of stiffness and dilate. So you are going to have diastolic dysfunction. So now we are going to discuss a few multiple choice questions in this topic. So first one, which of the following laboratory markers is more specific for diagnosis? As I already discussed, AST is not very specific because it can also be, it's also an enzyme which is produced by the liver. So it's not very specific to the cardiac tissue. Again, LDH, a bunch of tissues can produce LDH. Creatine kinase also, even though CKMB is specific, but it can mimic other tissues like CK from the skeletal muscle. So the answer here is troponin I. Next question, during the evolution of myocardial infarction, which of the following is a characteristic microscopic finding within 1 to 3 days post-infarction? So this is very easy. We know that within 1 to 3 days, we're going to have neutrophilic infiltration along with coagulative necrosis. So this is the answer. Granulation tissue formation is going to be formed after 7 days, 7 to 10 days. Dense fibrous scar around 2 weeks. Okay, so these are the answers. Next one. Which of the following is not a feature of tetralogy of Fallot? So first we'll revise what are the features of tetralogy of Fallot. We know there is pulmonary stenosis. We know the right ventricular hypertrophy. We know there is overriding of aorta. And then we know there is a ventricular septal defect. Okay, so ventricular septal defect is a feature. Pulmonary stenosis, yes. Right ventricular hypertrophy also, yes. So which is not a feature, it is left ventricular enlargement. So this is the answer. Now, according to Jones criteria, which of the following is not a, which of the following is considered a major criterion? So now we'll just revise the major criterion. We know the mnemonic, right? J is for joints. So arthralgia, yes, it is a major criteria. And then this is carditis, heart for carditis. This is subcutaneous nodules, erythema marginatum, and Sydenham chorea. So we know now arthralgia, not arthralgia, migratory arthritis, right? So joint and migratory arthritis. So erythema marginatum is a major criteria. Fever, arthralgia, and leukocytosis, since they're very non-specific, they're just a minor criteria. So when will you diagnose along with 2 minor criteria? When you can find a streptococcal infection. If it is confirmed, then you can diagnose with only 2 minor criteria. You can diagnose rheumatic fever. Okay. So I think we are done for this class. We'll meet in the next session in the cardiovascular system part 2. Thank you so much.